Today we have gathered here virtually through live webinar for the CME on the topic Falls in Elderly, Clinical Management and Physiotherapy Perspective, organized by Indian Association of Physiotherapists, Women's Cell Team, in association with Manipal Hospital, Bangalore. First, I would like to welcome our special guest today, that is our speakers. My hearty welcome to the eminent speakers, Dr. Anoop Amarnath, who is the chairman and consultant in geriatric medicine and also chief of clinical services, Manipal Hospital, Bangalore. We cordially welcome you, sir. Our second speaker is Mr. Vinod Narayan Swami, a senior neurophysical therapist from also Manipal Hospital, Bangalore. A hearty welcome to you, sir. Our second speaker is Mr. Vinod Narayan. We also have a special guest today along with us, Dr. Kshitija, DGM Operation, Manipal Hospital. Hearty welcome to you, ma'am.
Thank you.
We also have a special guest today along with us, Dr. Kshitija, DGM Operation. Today's session will focus on falls in elderly and how the elderly population can be managed in the clinical perspective, followed by the physical therapy perspective. And so the first session will be handled by Dr. Anoop Amarnath. Followed by, sir, over to you, sir.
Okay. Thank you, everyone. Thanks for the Academy of Physiotherapy for hosting this. Thanks to Manipal Hospitals. Am I audible? Is there an echo or is that okay? Everyone, thanks for the Academy of Physiotherapy for hosting.
Sir, you're audible, sir. There's no echo now. I've muted everyone.
Okay, thank you. So can we start the slide share, please? Okay, that's good. So again, once again, I thank everyone, the physiotherapy department, the Indian Academy of Physiotherapists, and the Manipal Hospitals Group for jointly hosting this. So what we'll do is we'll divide this talk into two parts. And in the first part, we'll talk about the medical aspects of falls in the elderly. And in the second part, our physiotherapy team will take over and talk about fall prevention strategies from the physiotherapy perspective. So next slide, please. Okay, let me just quickly check. Are you able to do the slide change, Sumit? Okay, so we'll talk about preventive geriatrics, and essentially the fall prevention comes under preventive geriatrics. So preventive geriatrics is the art and science of preventing disease in the geriatric population and promoting their health and efficiency. So what we actually look at is how to prevent not just diseases, but disorders also in the elderly. The reason why we say it's an art and science is because, of course, there are a lot of objective markers in terms of how we assess fall prevention. But also we look at in terms of the art of prevention, because not two elderly people are the same and each one have their own kind of underlying issues. So it becomes a very individualistic approach in terms of handling an elderly population. So if we can put it in full screen mode, I think that'll be helpful for everyone. So what we look at as a part of geriatric medicine, and specifically preventive geriatrics, is A, maintenance of health in old age by high level of engagement and avoiding diseases, early detection and appropriate treatment of those diseases. But most importantly, rather than cure, in the elderly, we look at how to a large extent we can keep the elderly independent and then ensure that diseases, all those irreversible diseases which are there, despite that, we try and maintain good health in them. Of course, a lot of it is not just medical, it is what we call as multidisciplinary. So there's a huge role played by the physiotherapy team and the occupational therapy team. So in a broad guideline, geriatric medicine and especially preventive geriatric looks at how to prevent certain diseases and disorders. And number two, how to make the elderly people as independent as possible in their day-to-day activities. So that's the overall focus that we'll have today, and with a specific focus on fall prevention. Next slide. So now we look at what are the specific risks that we have in the elderly population. I don't think we've gotten to the next slide. Sumit, are you able to move it to the next one? Okay. So as you all know, the elderly people are prone to a lot of issues. Infections are very common. Injuries are very common, of course. Psychological issues, degenerative issues. To a large extent, the degenerative issue may not come under the category of diseases, but it's more of a degeneration. Then there are risk of systemic diseases, increased risk of disability, and of course, we all know that there's an increased risk of death. But then if you look at all these things, the focus would be on falls today. And the reason why falls are very important in the elderly is because each and any one of these, which we have mentioned, the infection, psychological problems, degenerative diseases, systemic diseases, disability per se. So each and every one of this has an increases the risk of falls in the elderly. So it's, when I said earlier that fall is a multifactorial thing, it's important for us to look into what are the multiple factors which cause falls, because if each and every one of these are addressed, it improves our ability to prevent falls in the elderly. Next slide, please. Now, if you look at this particular slide, the reason why it is, falls have a big impact in the elderly. If we look at the incidence and prevalence of falls. Now, above the age of 65, in the first circle that you see, 1 out of every 3 people fall each year. So that's a huge number, about 33% risk of falls. As in when you age, if you look at the middle one, the amber one, people at the age of 72 plus, years, the risk of fall is almost every year. So as in when we age, even half a decade increase in age causes increase in the risk of falls, and the frequency is much more and the incidence is much more. So that's the reason we say falls are important. And then at the end of each decade, the risk of fall keeps going high. So now that we've seen the risk of falls, let's also look into what are the causes for falls. Now, what you see in the next set of slides, this slide is the 5 topmost causes of falls. And as all of you will be aware, the most common one is impaired vision and hearing. We know that as and when we age, the vision goes down, the hearing goes down. And this is one of the most important reasons why elderly people fall. The second thing is muscle weakness and impaired balance. So as and when we age, the muscles become weak and the balance also becomes weak. And we'll talk about a little bit more detail when the physiotherapy team presents this one. We know that his team present, but it's important to understand that I'm not done with that slide. Can we just go back? Yeah, thanks. So muscle weakness is one of the important reasons why people fall. And there is a specific term for this called sarcopenia. So as and when they age, the muscles in themselves become weak, irrespective of nutrition. So this is called sarcopenia, and it's one of the important causes for falls. Impaired balance, this is another thing which we'll focus on during the second half of the talk. But then this is again a very important cause for falls in the elderly. The third one is not medical related, but environment related, and these are called home hazards. Now, not just home hazards, but hazards across the environment. Say, for example, we tend to have these mats across in our houses, and then elderly people tend to fall and trip over that. Water on the floors, very smooth surfaces. So these are kind of reasons why elderly people tend to fall, and these are called home hazards or environmental hazards. The fourth important thing are medications, and this is something which we often see in hospitalized elderly people or those elderly people with multiple medications, and this is called polypharmacy. Now, the risk of polypharmacy is very high in the elderly. You might have seen that a lot of elderly people have a huge list of medicines. And for each condition, they tend to take 1 or 2 medicines, and that runs up to around 10 or 12 medicines in total. So polypharmacy is a very important reason for falls. And then when we evaluate an elderly person, we look at each and every of these medicines and ensure that the lung conditions like diabetes, hypertension. So as and when they age, the number of chronic conditions increases, and each and every one of these chronic conditions is an independent risk factor for falls in the elderly. So diabetes with either high sugars or low sugars, hypertension with either very low blood pressure or high blood pressure, cardiac conditions with irregular heartbeats and things like that. So each and every one of this chronic condition is an independent risk factor for falls. So these are the top 5 causes for fall that we identify as from the medical perspective. So the reason I've put this up is because when we do an assessment for fall, these are the factors that we look into. Now, coming to the next slide, which talks about how to assess a person for fall. It's called the fall risk assessment tool. Each hospital has their own set of assessment tools. But then specifically, if you look at whenever a patient gets admitted to the hospital or when we evaluate an elderly patient, it's always a very good practice and a part of the comprehensive geriatric assessment that we do a fall risk assessment. So I'll spend a few minutes on this fall risk assessment tool. So what exactly do we do when we look at the fall risk assessment? So number one, if you can see the scoring, so each hospital or each doctor follow different set of fall risk assessment tools. But then broadly speaking, the idea is to ensure that we assess the risk in terms of an objective marker of how these risks are. So if a person, an elderly person has had a recent fall, then the risk is so much high. So the more they fall, fall begets a fall. So the more the previous falls, the more the risk of further falls. So very important for us to take a history of previous falls. And as I said earlier on, in terms of medications and polypharmacy, a very important risk. So if you see the risk stratification, each one of them get a different score in terms of whether they're taking 1 medicine, 2 medicines, sedation. Sedatives are a big risk factor. You might have seen a lot of elderly people with some kind or the other of a sleeping pill, and these become independent risk factor for falls. Antihypertensives, BP medicines, again, are a very important cause for falls because a lot of the older generation, the antihypertensives or diuretics, things like that, they tend to cause the sodium to drop, and those are, an independent risk factor for falls itself. So very important that, when we assess an elderly person, we assess each and every one of these medicines because every one of them has the potential to cause a fall. But then the most important ones are the sedatives, the hypnotics, and the antihypertensives, and the older generation sulfonylureas, which tend to cause hypoglycemia. So low sugar, again, is a big risk factor for fall. So we need to ensure that when we do a fall risk assessment, all of these factors are looked into. The third one, when we do the fall risk assessment, is psychological factors. Anxiety, depression. So these are, again, very important factors which cause falls. So once they have a fall, that becomes a risk factor. And then once they have anxiety, depression, those are independent risk factors as well. The apprehension comes in that they might fall, and that causes imbalance, and that leads to fall. So it's like a vicious cycle, and it's more of a downward spiral from there onwards. So I think a psychological assessment is very important. Certain people with dementia and bipolar disorders, they are at a very high risk of fall. So a psychological assessment becomes an important tool for us when we are assessing an elderly person with falls. Having talked about dementia, cognitive testing is another important thing, because what we've seen is that the more severe the dementia, the higher the risk of falls. Of course, in late stages of dementia, what happens is the patient becomes bedbound. But before that, they do not have the cognitive ability to understand the risk of falls or understand the risk of imbalance. So I think when we're doing a fall risk assessment, and we do this as a part of comprehensive geriatric assessment, we assess the cognitive status. There's something called as the AMTS, abbreviated mental test scoring. So we do this on a scale of 10. So whenever the scoring is 8 or less, that is an indication of dementia. And then any cognitive dysfunction becomes a risk factor for falls. So when we look at an elderly patient, it's not just the recent fall, but also in terms of the medicines, psychological assessment, cognitive assessment. Now, there are certain things which automatically puts a person at a high risk of falls. So these are the automatic high risk statuses. And thereafter, we do a risk factor checklist. Now, what are these risk factor checklists? So the risk factors are, of course, as we said earlier on, in the top 5 causes of falls, vision. So it goes without saying that if a person has poor vision, the risk of falling is so much high. And then the mobility, you might have seen a lot of elderly people with sticks, walking frames, and things like that. So those are the people who are at an even higher risk of fall. So then that comes into the component of risk factor checklist. The third one is transfers. It's when a person is moving from, say, bed to chair or chair to walking position. So that becomes, a factor. So the easier an elderly person finds it to do these transfers, the lesser the risk of falls. The more difficult they find in terms of doing these transfers, the higher the risk of falls. The fourth one is ADLs, what we describe as activities of daily living. So the more easily a person is able to do these activities of daily living, the lesser the risk of falls. But in due course, what happens is their ability to do these day-to-day activities diminishes, and then the risk of falls increases. We talked about environment earlier on, so it's very important for us not just to look into the patient himself or herself, but also the environment in which he or she is. Because certain environments may not be elder friendly, like we always talk about child friendly environments, and this is similar to the elders as well. Are we putting a person in an elder friendly environment? I think that's some detail which Vinod and his team will talk about in due course. But falls are not just inherent to a person, but also the environment around it. So we need to look into, are there any mats on which they're tripping over? Is the surface very smooth that they don't have a grip? Is the lighting adequate? Is there a grab rail or a handbar which they can hold on to in terms of support? So these become environment risk factors. Then it is the two remaining issues about nutritional factors and continence factors. Now, nutrition becomes important because, as I discussed earlier on sarcopenia, if the muscles are weak, the balance reduces and the risk of fall increases. So nutrition assessment is something which we do. And a simple test that we do as a form of a blood test is the serum albumin. So whenever the albumin is between 3.5 to 5, it tells us that the nutrition is good. But whenever the albumin is low, it's an independent risk factor for fall. So when we do an assessment, it's very important to do the nutritional assessment as well. And finally, continence. The reason why we put that is because more often than not, the time when we see an elderly person falling is when they need to go to the bathroom in the night. And also when they don't have control over bladder and bowel, they suddenly get up and try to walk, and that's where they lose balance and fall down. So the continence becomes a big issue, and the more they're incontinent, the more the risk of falls, because the tendency is to suddenly stand up and go to the bathroom because they cannot hold their bladder or bowel, and those are the times when the elderly people tend to fall. So this is a fairly comprehensive fall risk assessment tool, And then it's important that at the time when we see an elderly person or when we're doing a fall risk assessment, we use these tools, or when we're doing a comprehensive geriatric assessment, we follow these tools. Because for two reasons: one, it gives us an objective assessment of their baseline, and number two, it also tells us that if when we repeat this, if the tests are showing an increase in the risk, so it picks it up objectively. And also it tells us which are the areas that we need to focus on. So if we notice a person is falling and then there is a polypharmacy, it goes without saying that we need to address that first. So this is a very comprehensive tool, and this is something which we use as a part of the medical workup. So probably after this, we'll share this fall risk assessment tool as well. So to summarize, in the last few slides, we've looked at why elderly people fall, what are the top 5 causes of falls, and then how do we assess falls using the fall risk assessment tool. In the next few slides, we'll talk about how we assess and how we do the screening and then the management of falls. So medical conditions become very important. So as I said, any of the chronic medical diseases, diabetes, thyroid dysfunction. So these are the fundamental things that we evaluate from a medical perspective. So HbA1c becomes important. Very tight control of sugars is a risk factor. In fact, we tell all the elderly people that even if your HbA1c is around 7.5 to 8, it doesn't matter, because the more tighter the sugar control, the higher the risk of falls. And there's a specific condition in the elderly called as hypoglycemic unawareness. So when the sugars go down, they are not aware, because if you see a young person with diabetes or a middle-aged person with diabetes, he or she is able to understand, identify hypoglycemia, become very hungry, you have the sweating spells, you have an intense urge to eat something, you feel very weak. So these are the signs and symptoms of hypoglycemia. But unfortunately, what happens in the elderly, the condition of hypoglycemic unawareness. So they don't realize that they're hypoglycemic and suddenly they fall down. So that's a big risk for fall. So the fundamental thing that we do as a part of medical workup is to ensure that sugars are not very tightly controlled, and then even a slightly high sugar is acceptable, whereas low sugar is much more dangerous. Thyroid dysfunctions, hypothyroid goes undetected in the elderly. So when they have severe hypothyroidism, mobility gets affected. They become very slow, lethargic, and that's a risk factor for fall. And on the contrary, hyperthyroid as well, when they are overactive thyroid, leads to palpitations, imbalance, and hypermetabolic state. So that becomes important for us to assess. Osteoporosis is another important issue, and we have to make that as a regular assessment, because even a small, what we call as a low intensity fall, like sitting in a chair and then slumping down, that can lead to fractures. So it's important that we look at from a bone perspective, are they osteoporotic, and how to address osteoporosis becomes an issue. Obesity, as I said, hypothyroidism and increased body weight causes imbalance, and that's another reason for fall. Hypertension as well, again with like a diabetes, unawareness of hyper or hypotension is very crucial in the elderly. Sometimes the very common condition that we see in the elderly is isolated systolic hypertension. That is, only the upper systolic blood pressure goes up, whereas the diastolic remains. And as and when the systolic blood pressure goes up, they get giddiness and falls. And on the contrary, hypotension, a lot of people, elderly people, take medicines and they keep on taking the same antihypertensives for ages. And then, unknown to them, the blood pressure tends to come down, and that's one of the reasons for fall. We talked about cognitive impairment, we talked about depression, and we also talked about hearing defects and vision defects. So when we do a comprehensive geriatric assessment, these are the individual diseases and disorders that we look into. Next slide. So a lot of times that we see is each of these chronic diseases, whether it's diabetes, hypertension, dyslipidemia, hypothyroid, each one of them lead to an end organ damage, whether it's cardiac dysfunction or renal dysfunction. but most importantly cardiac, because as and when we age, there's something called as the heart failure with preserved ejection fraction. So the ejection fraction is good, but then there is a reduction in the overall heart activity. So maintaining blood pressure and evaluating from a cardiac perspective becomes a very important thing, because with the elderly, they'll remain asymptomatic. They don't come in classically with having chest pain, palpitations and things like that. Just unusually lethargy or being lethargic or reduction in physical activity. All of these are an indication of underlying cardiac problems, which in turn leads to falls. So improvement of physical activity and keeping them in a certain physical health goes a long way in terms of preventing falls in the elderly. Next slide. So in summary, what we do when an elderly person comes in is we do the fall risk assessment. We look at the medical conditions, screening for diabetes, hypertension, cardiac problems. We review the medications, as I said earlier on, polypharmacy. In fact, we had done a study which showed that the potential inappropriate medication prescribing in an elderly person, and this was a study which we did in UK. So almost 30% of elderly people have an inappropriate medication prescribed, and that inappropriate medicine may be a high dose or a suboptimal dose or a wrong medicine per se. So that becomes important to evaluate medications and polypharmacy. And then, of course, comes, once the entire medical workup is done, then we, ensure that the physical activity, the walking aids, and those kind of issues come into the picture. And that's where we work very closely with the physiotherapy and the occupational therapy department. So this is something in broad about using walking aids and staying active. So, of course, we will talk about it in detail when Vinod takes his session. And lastly, next slide, please. We also advise, apart from the physiotherapists and the occupational therapists, physiotherapists assessing them, certain occupational therapy interventions as well, like having grab rails in the bathroom, improving lighting, removing the loose rugs and things like that, wearing non-skid soles. So these come into the domain of occupational therapy. So what we intend to do is a multidisciplinary assessment and management. Yes, we take care from the medical perspective about evaluation of falls, risk assessment, medication management, health management, but a big chunk of it comes from physiotherapy and occupational therapy. So this is in brief about the medical management of falls. Next slide. So we hope a lot of them go to cutting this particular cake at their 100th year. That's what we intend to do. And I'm happy to take a few questions in the next 5 minutes, but the second half will be handled by the physiotherapy department.
Thank you, sir. It was indeed a very informative session focusing on the importance of falls and how to identify them, and also especially the contributing factors which you've quoted, and also the screening recommendation, and finally the tips for prevention is really a take home for all the participants. We have few questions from our participants, sir. The first question is, what would be the frequency of fall in geriatrics we come across in India, sir? Can you throw some light on it?
Yeah, I think it's, the frequency of falls in the elderly is very high. And as in one of the slides which we said, anyone above the age of 65, the risk of fall becomes once in 2 years, and above the age of 80, it is every year. So the risk is very high and almost as high as 30% per annum.
Thank you, sir. We have a few more questions, sir. The next question would be, what would be the strategies to prevent the falls in the elderly, sir? Can you give us some strategies?
So I think we can divide the strategy into 3 parts: the medical management, the physiotherapy management, and the occupational therapy or environment management. So we take care of a lot of physiotherapy, medical management in terms of evaluation of medical problems, addressing their chronic medical conditions, polypharmacy, sarcopenia, and nutrition. So that's 1/3 of the entire prevention strategy. The second, third, and the last third is the domain of physiotherapy and the occupational therapy, the environmental prevention. So I think probably in the next half of the talk, the physiotherapy and occupational therapy will be covered. So I think it is a multidisciplinary management, including all these three things.
Thank you, sir. Sir, the next question would be, are there any medicines that would lead to or cause risk of fall?
Right. As we discussed earlier on, each and every medicine honestly has a risk of fall, but some more than the others. Some like diabetes medicines, some the older generation ones, specifically sulfonylureas, which cause low sugar with hypoglycemic unawareness. That is number one. Diuretics, which tend to cause sodium imbalances, those are the other. Sedation and antipsychotic medicines, these are the third important category of medicines. So some of them are very commonly used and most commonly cause falls. So I think these are the major medicines that we need to look into.
So one more important question, sir. How we will be able to differentiate the falls which are occurring in the neurological disorders and the one which is occurring in aging?
I think that's a very important question. This is where the comprehensive geriatric assessment comes in. So what we tend to do is when we do the assessment, we also evaluate the autonomic nervous system. Some of them have postural hypotension. So those are the neurological reasons why they tend to have a fall. Carotid sinus hypersensitivity and kind of undiagnosed stroke, those are the things. So when we do the evaluation, the tilt table testing, so these are the things which we do when we evaluate falls. And those are some of the ways in which we detect the cause of falls. And then, of course, the non-neurological things is when we assess from the cardiac perspective and mobility perspective. But I think certain specific evaluations like tilt table test, carotid sinus hypersensitivity, so those are the ones which will tell us why these elderly people tend to fall.
Very well explained, sir. Thank you, sir. One last question from a participant, Dr. Jyoti. She's asking, given that there are side effects of the drugs, by controlling the drug intake, can the falls be reduced? And can physiotherapy be replaced in controlling these falls? What is your recommendation, sir?
No, I think all the three, medical management, physiotherapy management, and environmental management through occupational therapy, all these three are indispensable. I don't think one can replace the other. All three need to work in tandem and then evaluate the cause of falls, evaluate the risk factors, and then specifically address those risk factors. So I think, as I said earlier on, this is a multidisciplinary involvement. So all of them have a very strong role to play. And then if it's a specific medicine causing falls, when we do the medical assessment, we tend to pick on that and try and replace that particular medicine, because most of them would be used for chronic conditions which we cannot stop. So we tend to replace it with a safer medicine.
Thank you, sir. We are at the end of the question answer session. I thank Dr. Amarnath for his valuable time. Sir is one of a very few geriatrician in the country, having a specialization in geriatric medicine from Royal College of Physicians in London. Sir, thank you so much for sharing your expertise in the clinical knowledge. And geriatrics is a field where all of us have to explore a lot, and having your experience shared, we have no words to express our thanks. Thanks a lot once again, sir.
Thank you. We all grow old at one day or the other, so we are all going to get there eventually. Thank you.
Thank you, sir.
Thank you.
Now I welcome Dr. Kshitija, DGM Operation of Manipal Hospital, the special guests of today's webinar. Ma'am, I request you to say a few words, ma'am.
I take this opportunity to thank IAP Women's Cell Karnataka team, especially to host this kind of innovative platform where we can share knowledge with everyone. We can have new channels of communication, and I believe that there has been enthusiastic response with more than 500 plus participants across the globe. So I think that's something which is very good. And even in this pandemic times, we have utilized this opportunity to make good and share knowledge. So thank you so much. I would like to personally thank Dr. Sumita, the state coordinator, Dr. Kalai Selvi, the state joint coordinator, Dr. Richa Singh, state sub-coordinator, Dr. Veena Payas, state sub-coordinator, Dr. Shanti Karthik, coordinator, and Dr. Pooja Pandey, Bhavana, sub-coordinator. Thank you all. Thanks a lot on behalf of Manipal.
Thank you, ma'am. Thanks for taking your time and then being a part of this webinar, and also helping us and supporting us for conducting this webinar. Our hearty thanks to you, ma'am. We will go on to the next session. The next session is on the physiotherapy aspect of falls and geriatrics. It will be taken by Mr. Vinod Narayan Swami. He is a senior neurophysiotherapist in the Department of Physical Medicine and Rehabilitation in Manipal Hospital in Bangalore, and he's an expertise in neuro rehab techniques. Over to you, sir.
Yeah, thank you, Sharada. Good evening, everyone. It has been a pleasure to participate in this kind of program, and I would like to thank first of all the IAP Women's Cell and Karnataka branch. Special thanks to the head, Sumati ma'am, and all the coordinators, sub-coordinators. This has been a fourth. This has been a fourth webinar actually from the Manipal Hospital side, and we are indeed happy to participate in this kind of platform. And shall we? No, not this one. Just a minute, just share my slide. Today's topic, like falls in elderly from the physical therapy perspective. Has been a technical glitch actually. Yeah. Today's topic is falls in elderly from the physical therapy perspective. Just before me, Dr. Anoop Amarnath would have given you guys a wonderful talk about the role of multidisciplinary role of managing the falls actually. No, it's here. Can you guys see the screen?
Yeah.
Yeah. Why physiotherapy? Actually, that's a thing which Dr. Amarnath was also stressing on the importance of physiotherapy. Right. Aging is an inevitable process. As the age grows, there are a lot of physiological and physical changes happening in the physiological changes happening in the body. There are multiple comorbidities and complications, usually associated with there are many multiple comorbidities and complications with the aging process actually. One such, complication is the falls, which is more prevalent among the elderly people nowadays, which more frequently we are witnessing. There are multiple risk factors, associated with the falls. As a physiotherapy, how we are, tackling that, how we are, trying to reduce the rate of fall, or else, otherwise, trying to prevent the fall. That's the biggest concern, like dealing with the patients. As a physiotherapist, we need to treat the patient as a whole. For example, if a patient comes with, for example, pain, arthritis pain, or shoulder pain, or else the neck pain. Generally we usually treat the symptoms, and then we suggest few exercises, and then let it. I will say all the best to the patient, and we leave it off as such. It's quite important that we need to stress the importance of the exercise to the individual, also to the family members, the beautiful concept of exercise, how it can give the long-term effort in not only managing the particular symptoms, but also, preventing the further complications like falls, which is more prevalent, as I already said. So, but when you tell them to do physically active, and when you say them to do the exercise, there will be multiple barriers, in case of elderly individuals they face, in terms of personal, in terms of environmental. For example, personally, if you say, ask them to do the exercise, and they will say, already I'm done with so many medications. I'm already tired of, like physically I'm retired. Why I need to continue this exercise and all those things. Which is sometimes it may be boring for them. Sometimes it may be not interestable. It's not interesting for them. It's quite important for them, to understand their moods and perspectives. How they approach the exercise and physical activity. And sometimes there won't be any motivation from their end, like to do the physically, physical exercise. In terms of environmental, if you see, if you suggest a few exercises in the clinical setting or else in the OPD, and if you ask them to continue at home, it is very, it won't be a feasible aspect. There won't be a lot of restriction at home. There won't be any assistance over there at home to take care of them. It's very difficult for them to come to the OPD to continue their care, and then to for the long-term effort. So these are the multiple barriers, usually they face us, and therefore, they won't bother to do the exercise, to take care of themselves. How to overcome in this, in the sense, we need to create a strong awareness, to the individuals, and especially elderly people, and also to the family members, how important the physical exercise aspect. And we need to strongly assure them that, and we need to instill the belief in the process, of getting recovery and preventing the complications like a falls, which has multiple risk factors. So, while understanding while understanding how the fall happens, and or the complications which are associated with the falls, it's quite important for physiotherapists, to be aware of what are the modifiable risk factors, and what are the non-modifiable risk factors or unmodifiable risk factors. In case of modifiable risk factors, it's we can intervene over there. In case of unmodifiable risk factors, we can give them suggestions, or else we can compensate with certain interventions. So it's quite important for us to understand this, what are the modifiable and unmodifiable risk factors, and basic concept of what is balance, that we need to know. Because as doctor is told, it happens because of impaired balance. What's a balance in an individual? Balance is an dynamic process. It's nothing but a posture stability. How you keep ourselves stable in the environment. That's what posture stability. How we are maintaining our center of mass over the base of support. That's a balance. And if you if you want to understand further, it's like we need to understand the physiology of balance. It's a interaction of all the three important systems: the nervous system, musculoskeletal system, and the environment itself. See that without the integration of these factors, it's quite difficult for the person to be balanced in the space or environment where he is. So in terms of musculoskeletal system, it's our joint range of motion, our muscle power, strength, or else endurance, and then the sensations, touch, deep sensations, all those things. And in terms of balance, in terms of nervous system, there are three important factors, like sensory processing, and sensory integration, and the motor programming. So sensory processing, in terms of how it happens, sensory processing, it happens because of the inputs we get from the periphery. For example, the visual system or vision, and then vestibular system, which is located in the inner ear, and then the joint sensation and proprioception. Those all carry forward the balance, carry forward the information from the periphery to the central processing unit, called as a sensory integration area, called as cerebrum, and cerebrum, especially the motor cortex area, and then cerebellum and basal ganglia, and where the integration of the sensory processing, integration of the sensation happens, and then followed by the motor programming, how it responds. The brain responds to the situations, demands through the vestibulospinal tract and the vestibulospinal tract and corticospinal tract, and thereby giving the more balanced in terms of motion and in the space. And the contextual factor is an environmental factor. Even if the nervous system and musculoskeletal system even if the musculoskeletal system and nervous systems like very integral and it's happening, it's working properly, the contextual system environment itself can create a lot of disbalance. If for example, if there is a improper lighting, if there is a clutter on the space, even that can contribute the fall in an individual. So that can cause the disbalance in an individual. So understanding this is very important. And how the balance control happens, there are three different or four different types of balance controls are happening. Static control, dynamic control, anticipatory control, and then reactive. Uh, these are four types of balance controls. Static in the sense ability of a body to be in a stable state, in a stable position. That is a static. And then dynamic, during the dynamic activity, during the movement, how we are balanced. That is called dynamic balance control. And then reactive in the sense of how the body is responding to the external force. How the body is managing to make themselves balanced in the external towards the external force is a reactive. And then anticipatory, how positional control is happening to the expected disturbance. That is anticipatory. So in order for the body to be more balanced, there are the strategies, motor strategies body performs to be more balanced. Specifically saying, body adapts the mechanism to deal with the external perturbation. Those are ankle strategies, hip strategies, swing strategies, and then shifting strategies, and then weight shifting strategies, and a combination of all these. So in case of ankle strategies works from the ankle. When a person is standing and if sways front and back, from the ankle level, it happens during the small perturbation. You can use the ankle strategy to manage the small perturbation in the space. And then in case of hip strategy, when there is a external force, it pushes the person to the near the limits of stability. That time, the individual uses the hip strategy to prevent themselves from the fall. The hip strategy happens from either by forward bending or else backward extension. In case of hip strategy, when someone pushes from the body and when the person falls forward, it starts from the proximal, abdominal muscle starts to work first, and then followed by the quadriceps, and then dorsiflexors. In case of posterior perturbation, during the hip strategy, in the backward extension, the paraspinal muscles and then hip abductors and gastrocnemius muscles starts to perform. So, and then the weight shift strategies, where leaning on one leg and standing on one leg. During that time, it's important for the hip abductors and the elevators, inverters, and all those things work to maintain the body in the stable state. So, therefore, the muscle plays an important role in providing a stable environment for the body to execute a motion in the space. Therefore, the adequate strength of the muscles are very important. So, when there is when the fall happens, when there is an impairment in any of these structures, either in the neurological structure or else in the musculoskeletal structure or else in any external contextual factors, it leads to a fall in an individual. In case of neurological thing, there may be a vision problem, there may be a vestibular issues, like unilateral vestibular hyperfunction or else bilateral vestibular hyperfunctions. In case of musculoskeletal system, there is a chance for like arthritis, pain, and improper postures, and reduced flexibility can cause the falls. And in case of contextual factors, like as I already mentioned, there was a lack of light and like clutters on the ground. All these can lead to the fall in an individual. So the integration of the nervous musculoskeletal system and contextual factors is important. If there is any impairment, if there is any deviation from those, can cause a balance dysfunction in an individual that can lead to a fall, and further consequence of falls are well known. So, how we do that, like assessment, how to assess the whether a person is, or the individual, elderly individual is balanced actually. Already just before me, doctor has spoken about the FRAT tools, actually fall risk assessment tool. But I categorized into the two different aspects, general and specific. In general, like it's in general, it's apart from the normal assessment, like about their vitals, all those things. It's quite important to assess these factors like fall history. Uh, how many times the fall has happened before, or whether they experience any fall in the previous time, or else what in which direction they usually fall down. Whether they when they fall, whether they go on one side of the body, one side of the environment, to fall, and then what are the surfaces they are dealing with, and what are the environment they are looking, and all these things, very important while assessing the fall history. And then cognitive status. A simple tool of MMSC can be used to assess the cognitive function of the patient, because this can help to identify whether the patient is having any uh, like dementia kind of conditions or something. And then, as I already told, musculoskeletal system is very important. The sensory and motor assessment is to be proper, like vision, proprioception, vestibular, um, and strength of range of motion, flexibility, and endurance are very important in a general assessment to understand whether those functions are working properly or not. And in environmental assessment, like it's very important. Uh, we can, it's very difficult from the hospital or OPD setting to assess the environment, but we can ask the individual family members to take the photo of the home, in case if they are willing, like so that we can suggest, what the modifications, all those things. So it's quite important to assess the environment also, as already doctor also touched upon on this. And then specifically, like is there any balance deficit in the patients? For that, we need to assess using the specific balance assessment test. As I already told, there are four important types of balance control: static, dynamic, and anticipatory and reacting. These are the tests, which can be used to assess those balance controls. Static, in case of Romberg test and Singlet stance, can be used. Romberg test is something, uh, very reliable, and it can be easily applied in a clinical setting to understand whether the proprioception is working properly or not in an individual. We just ask the patient to open the eyes and stand with a narrow base of support. Thereby, if there is any deviation or any sway, we assess, and then followed by closing the eyes. In case if the patient, while closing the eyes, if there is any throwing of the off balance, they go for off balance. It indicates that the test is positive. The positive Romberg test, it indicates that sensory ataxia or proprioception loss. Singlet stance, it's very difficult for elderly people to do that, because they may have some multiple other complications like arthritis or something, but it can be used in case of age like 60 years or 55 years to assess whether they are having the single leg stance, stability. We ask them to maintain the balance for 10 to 20 seconds, to assess the unilateral proprioception. And then a dynamic case, dynamic is actually to assess whether they are able to manage themselves, while doing the transfers, whether doing the navigating in the environment. For the dynamic balance control is very important. We can assess by using the simple test, sit to stand in 5 times. It's maybe sounds very easy actually, but in case of elderly individual, sit to stand doing the 5 times, it's very difficult. Within the stipulated time of 15 seconds, if they are taking more than 15 seconds of time, it indicates that there is the complication in managing the dynamic activities. And in case of anticipatory and reactive, there are anticipatory in the sense, when you anticipate the external perturbation and how you are reacting to the situation, that's the anticipatory control. And in that case, you can use the functional reach test and multi-direction reach test. Functional reach tests are very highly reliable, and the patient how to do the conduct the functional test is, the patient has to stand and then close to the wall. The marker we need, actually ruler marker we need, with a flexed shoulder, and then he has to reach forward to the marker. In case if we can reach more than 20, it indicates that the patient is having absolute stability. In case if there is a less than 10 inches, it indicates that patient having a problem in case of hip strategy or else anticipatory strategies. In case of reactive, it is like perturbation, legs like we throwing off balance. When there is a huge amount of force, acts on an individual, how they are reacting to the situation, how they are managing, either by using stepping strategy or not. So that is a reactive control. For that, we use pull test and push test. Pull test, we have to stand behind the elderly individual, and we have to pull them from their shoulders. In case if they have a good balance, actually, they won't come back, or they won't take a step back, to balance themselves. Instead of that, they use their co-contractor muscles, and they will try to balance themselves. In case if there is a need, they will take one step or two steps back. It depends on that. We need to assess, rating 0 to 4, whether they need really assistance to manage themselves for their balance, or else whether they are throwing really off balance. So these are some of the specific balance tests, we can imply on the individuals to assess that, apart from the general. These are outcome measures for fall risk assessment. Uh, these are specifically, outcome measures are very important, because this will indicate, how our strategies are working out on the individual. Whatever the test, over here we display, if you perform, and then if you take that, as a measure, we can, after the intervention, we can check back, and then we can try to find out which level of function they are right now. So it's quite important for the outcome measures to conduct. For this, there are tests like Berg balance test, Trinity performance oriented. It has two components, balance and gait also. In case of Berg balance test, highly reliable and varied tool, and usual score, perfect score is 56. If there is anything less than, like 46 or something, we can assess that, there is a difficulty in managing the day-to-day activities because of the dysfunction in the balance. And timed up and go test is a simple test we can conduct in the clinical settings very easily. Patient has to sit, and they have to get up, and they have to walk for 3 minutes, and they have to come back to the same position. Usually it takes a minimum of 13 seconds. For LDG, in case if it is more than 13 seconds, it indicates that there is a chance for the high risk of fall in an individual. And 4 square step test and dynamic gait index are very essential. 4 square step test, in that we have to place a cane, in a plus manner, it's a symbol of plus, and then we have to ask the patient to go around from 1, 2, 3, 4, and then again in an anti-clockwise direction, we have to ask them to walk. If there is a test, if it takes more than 15 seconds to perform the test, indicates there is high risk for the fall. And dynamic gait index and functional gait index are especially used for assessing the mobility aspects, and functional gait assessment used for finding out the vestibular structure, any defects. Okay. In case of dynamic gait index, the maximum score of a perfect score is 24. In that, if there is a score, if the patient or elderly individual scoring less than 80 or 90, indicates that there is a more chance for falls during the gait activities. And functional gait assessment is another tool, it can be used for vestibular, as I already told. It has a score of maximum 30, and then in case if there is any score which has less than 22 or something, indicates that there is a chance for the fall. And ABC and fall efficacy scales are used for finding out whether they have any fear during any activities in their day-to-day livings. And ABC, it has 100%. We read it we take it in 100%. In that, if there is anything less than 67% of score, indicates that there is a more chance for or more risk for fall, especially because of fear. And fall efficacy is another tool which can be used to assess whether they have any other, again, any activities, in doing the daily living, if they have any fear in performing the activities. It has a 70. If there is a score above 70, it indicates that there is a high risk for fall because of fear. Out of all this, I'll use the Berg balance test and Trinity performance test for assessing the mobility aspect, and especially the bed mobilities, and then dynamic gait index and functional gait index used for the gait aspect, and then ABC scale, activity balance specific scale, for and fall efficacy scale to assess the fear within the individual to carry out the daily task. Apart from this, we can add one more scale also, dizziness handicap inventory score, which can be useful for the patients who have the balance dysfunction due to the vestibular origin. So we have broadly seen that how to do the assessment in a general way, and then in a specific balance, specific balance for the 5 types of balance control, and then outcome measures for the fall risk. So now, what are the points which we need to consider before intervention is, first thing is a safety measure. It is one of the very important, as a therapist, we need to take care when we are dealing with the patients. It's necessary that we need to be, when we are intervening, it is necessary that it has to happen in a safe environment, first thing, and then with proper lighting, all those, and then if possible, we have to use the gate belt or safety hoist to control. We have to protect them from the fall. and then we need to stand whatever the kind of, even if it is static or a dynamic, if possible, to some extent we have to stand besides or nearby to the patient to avoid the fall, all those things. Those are the few safety measures which from the therapist side we need to do. And then in case of risk stratification is one thing. Based on the assessment, it's very important for us whether how to identify, like a risk, whether it is a low risk candidates or high risk candidate or else the moderate risk candidates. So in case of low risk candidates, we have absolute strength and balance. It's quite as an adjunct to the other forms of physical therapy. We can add the balance exercise, and we can advise them to carry or conduct all those sessions at home also. In case of a high risk, it's very necessary important. It has to happen through a supervised manner. For that, they have to come to the OPD, or else therapist has to visit to the home settings, because those high risk candidates, through the outcome measure, if we find out, we should not leave and do the exercise on their own, because there is a chance for again go off balance doing the balance kind of exercise. And it has to be in a graded progression in the sense, whatever the kind of state, if patient is having a only problem during the dynamic activities, it's not necessary. It should not be like we should start from the dynamic. It has to start from the static balance control, because there is a chance for again high risk for it, because we can't increment. We can't go increment. We have to start from the base actually, and it has to go appropriately, because there is again the chance for the fall is more. In case of assistive device, it is quite important that rollators are can be useful for the patients rather than doing normal walkers actually, because rollator can easily able to navigate them in the environment rather than walkers. Walker they have to carry and keep it forward. That will be very difficult task sometimes for elderly people above 75 years of age or 80 years of age with the balance deficit, especially in the dynamic aspect. So rollators are safe actually. And then in case of canes, it's quite important that we need to tell them to use the quadripods actually. And in case of footwear, it is quite important to identify what kind of footwear selects the individual. In case of if you are intervening the patient using the ankle strategies, for example, vestibular kind of vestibular structure, if you are addressing that time, it's quite important for they have to use without footwear, they have to do the exercise. At the same time, if you are using the static or dynamic control kind of balance exercise, it's quite important to wear proper footwear actually. These are some of safety measures during intervention. And in case of shoes, like the heel collar has to be, even if you press, it has to give the resilience. And then the sole geometry, in the second picture on the top, it has to be little bit of curved, so that it gives a more stability while walking. And in case of straps, instead of laces, you should use that velcros. And in case of sole, it has to be good well threaded actually, so that it avoids a slipping surface. Even in activities in the slipping surface, a foam surface can be possible. And then the sole has to be flexible, and it has to be resilient during the activities. So based on the intervention, based on the outcome and assessment, we can categorize the people into the high risk, low risk, or moderate risk. Okay, in case of the scores are, we can, if we know the scores. In case of low risk individuals, it's quite important that they have to go through the short-term balance training exercise along with the other forms of exercise. As I already told, to manage, to get the balance control, there are adequate muscle power has to be there. So it is quite important that you need to strengthen the lower extremities. So in case of lower risk individuals, we can categorize them. We can, without supervision also, we can suggest a few strengthening exercise and flexibility exercise to carry out. But in case of moderate risk and high risk, individuals, we need to intervene them with utmost supervision. And as I already told, we need to progress them through the graded way. Usually, in case of balance dysfunction individuals, it's quite important that they directly intervene on the balance or coordination kind of exercise on the first week or second week itself. These are some we got it from the whole settle. And in the first week itself, we just try to focus on gaining the strength and getting the flexibility in individual. Like try to understand them. Try to teach them a few strengthening exercise and flexibility so that they will be comfortable in that aspect. So in case of strengthening exercise, the minimal threshold to do the strengthening exercise, minimal weight, to use is 2.4. That's quite important because we can't intervene with the 4 kgs or 3 kgs or 5 kgs. It's the minimal weight to intervene is for all the ADL activities, 2.4 is necessary. So we can start with less than 2.4, maybe 1 kg weight or 2 kgs of weight. And it's quite important to teach them flexibility exercise of the lower extremities and upper extremities in the first week. And in the progression of weeks, we can start with the basic balance exercise apart from the flexibility and strengthening exercise. Especially the strengthening exercise in the sense of lower extremity, quadriceps, gastrocnemius, and hip flexors and extensors and adductors. And in case of flexibility, again, you start stretching the hamstrings and the adductors. And coordination exercise depends on, in week 2, coordination exercise, you prescribe balance exercise, you prescribe based on the assessment, what it's really needed for the individual, whether it is a static balance, whether or it's dynamic balance, or whether any other structures are involved in the form of vestibular or else proprioception. Based on that, select the balance exercise. And then it is quite important not just to know the balance exercise alone can help. You from the 3rd week onwards, you start progressing the walking pattern. Ask them to encourage go for walking and try to teach them few postural exercises, because there are postures like most commonly noticeable in the elderly age, like thoracic kyphosis. We need to teach them those kind of postures, throw them off balance. Those kind of postures will make the center of mass go off to the base of support. So it's quite important to teach them proper postural exercise so that they can manage their falls actually. So it progressed to 6 weeks. These are short-term, program or protocol actually. In case of long term, it's quite important to continue all these forms of exercise. In case of low risk, we can teach in other forms of coordination. We can progress coordination. But after the 6 weeks of time, just go back and try to find out what kind of what kind of progression they have made actually in terms of balance. That's very important. For example, start with the static single leg stance, and then progress to tandem stance, and then dynamic, like standing on the foam surface, it's like a dynamic balance, and then this is something which is very these are exercises which cognitively also make them to think. If for example if you make them patient to do the activities like handling a secondary task like throwing the ball and catching the ball, will help them. It will cognitively, it will make them think. They are counting the numbers, and if they are doing the activity, that will include dynamic activities. And these are something which we can incorporate for improving the dynamic aspects. Standing on the foam surface to challenge the proprioceptors and also the vestibular. It's multi-directional reach kind of activities we can teach them. Then challenging at the cognitive level,
blue,
and also the
red,
combination or pattern of
blue, red, green,
and crossing the obstacle is one of the important for a reactive kind of postural balance control training. And then this one, closing the eyes and making the patient walk or elderly individual walk can challenge the vestibular structures, and we can use this kind of training for in case of any vestibular deficits. Kicking the ball again for reactive kind of postural training. Is one dynamic with weights we can train. Elderly people usually have the difficulty to get up from the chair and couch or from the couch. This kind of activities will improve their dynamic performance. And walking on the line or horizontal beam can be challenging for the elderly individuals, and particularly because it is more commonly reduced in the elderly individual. These kind of virtual training can also be done in case if you have a sophisticated balance master. These are all anticipatory. You know the targets, and you want to reach the target. By challenging the limits of stability, thereby you improve anticipatory kind of balance. It can be done on the same surface in case if you have a proprioceptive effects. And balance master, it can be quite useful in case for all forms of challenging with eyes open and the eyes closed actually. The velocity of the swing is measured to identify whether the patient can able to reduce the velocity post intervention. That is, with eyes open, is having a velocity of 7.4, and with eyes closed,
Eyes closed. Eyes closed.
thereby we can identify whether the improvement of the intervention can be possible. And this is a simple Otago exercise program from the University of New Zealand. And those who can't visit the clinic or else settings, they can participate in this kind of program at home under the supervision of family members also. And usually progress from easy to odd level, start with the both hand support to the single hand support. And then progress to no hand support. These are some of the lower extremity strength exercises, especially targeting the ankle muscles and then knee muscles and then hip muscles. Especially hip abductors are very important. And then in case of balance training, you can try whatever I showed actually: tandem walking, tandem stands, heel walking, toe walking, sit to stand kind of activities. This can be simple and effective tools, to deal with the elderly individuals at home to improve their balance actually. Then what to expect, post intervention? It's very important that we have to rethink about, or we have to go back to the again outcome measures to find out whether is there any change in the functional activities of the individual, whether there is a change in the reaction time, or whether there is a specific test which was found very difficult during the post pre-intervention can be addressed, and can be possibly do during the post intervention. And improvement in the gait parameters, whether they can able to achieve the functional task as I already told. And more importantly, it has increased the confidence level and reduce the fear of an individual or not. That has to be addressed to be checked. And then what are the prescribed it has to complete, not necessarily that only 6 weeks of schedule you need to stick to that. They have to continue for the long-term efforts actually. That is very important. And these are the reference. And with this, thanks to the IAP Council for providing the opportunity to carry out this.
Thank you, Mr. Vinod. That was quite a complete package on the balance impairment, which is one of the important factors for fall. So has thrown light on the right from the mechanism, all possible assessment tools what we have, and also what are the important factors we have to see before the intervention. It was quite a take-home message, and also sir specified on the multimodal exercises, which is a need for all the physiotherapists to look into when we are designing the balance protocol for the patient. And also finally, the Otago home exercise program is definitely a big information for all of us, that to throw emphasis on the home program. Thank you, sir. We have few questions from our participants. The first question is quite interesting. That is from Dr. Indumati. So her question is on your recommendation of, we have a lot of patients coming into the outpatient. So do we have to screen for fall risk? Do we have to screen for fall risk irrespective of the age? What is your take on this, sir?
No, if fall risk usually, happens after the elderly individual, like most common in the elderly individuals. And I don't think so it is needed. If they have adequate strength, in terms of musculoskeletal structures are integral, and it's not necessary to undergo the fall risk assessment, I feel so. But in case if they are above 50 or 65 years of age, definitely we can go for assessing the fall risk. At least if not all the fall risk assessment, at least you can go for one bed balance scale. And in case if they are complaining any finding any challenges in that, you can address that actually. So in case if it is above 65 years of age, definitely you can go ahead. But if it is like less than 60 or 50 years of age, it's not necessary, I guess. So to assess the fall risk, all those things, in case if they have a good adequate strength.
Thank you, sir. So the next question is on related to yoga. Most of us do yoga, and there are many sessions which are coming up in online, and then we see sessions on our Prime Minister Modi doing yoga and emphasizing on that. So this question from a participant is like, yoga posture of standing on one leg, should it be avoided at the age of 70?
No, it's if in case if they are able to perform that, it's why they need to stop that. Actually, they can do that. But in case of an individual or elder individual who have some arthritis issues or else any other proprioceptive problems, it's very difficult actually to manage it, because it needs a multiple level of strength actually from all the levels, from the hip and from the knee. So there is a chance for them to get injured also. So I don't suggest actually, but in case if they are having the practice over that, and if they can do that, why not, they can continue over that.
Thank you, sir. So the next question is on Tai Chi exercise. We keep hearing a lot of jargons, Qigong exercise, Tai Chi exercise, and many more terminologies is coming in. So patients quite come and ask us, it's a Google age. So what do you recommend, sir? Can Tai Chi exercise, from your clinical experience, Tai Chi exercise can be of help? Can it tackle balance problem in the elderly, sir?
Tai Chi is a form of exercise, but we don't have experts over there here in India, especially in our community actually. But you can incorporate all those kind of Tai Chi kind of exercise. It has multiple various forms actually. You can't incorporate in other forms of exercise. But if Tai Chi alone can improve the other forms of like functional activities in individual who have some balance issues, I don't think so it will address, because mostly it is a static kind of exercise within the very a small space, it happens actually, like so, and it's very slow in frequency. Of course it improves the balance actually to some extent, but it won't help, I guess so, to improve the functional activities, especially in the elderly individual. So you can do it, but if you have a target of improving the functional dynamic activities, I don't think so that will help.
Thank you, sir. As you rightly said, the expertise and competency of a therapist to execute the Tai Chi exercise is what has to be looked into, as sir rightly mentioned. So the next question is on the dementia patient. So the participants are asking like, how far the balance exercises are reliable in dementia patients?
No, I think Dr. Anoop Amarnath also has told actually about that. You have a disability rating scale, dementia rating scale. In that, in case if you feel that the patient having some cognitive issues, or else especially in terms of attention, in terms of memory, it's very difficult actually in the early stage of progression and early stage of disease like Alzheimer's and all. You can teach them a basic balance exercise, but I don't think so. Dementia, as it progresses, it's very difficult for them to do these kind of activities, even a small like gait also, like even a small distance of walking also. So they will get into bed bones. So it is not that reliable actually, balance exercise. But at the early stage, with other comorbidities, we can prevent this by using this balance exercise.
Thank you, sir. So the final question is on unilateral vestibular hypofunction. Are there any specific exercise to treat this, sir?
Yeah, there are specific exercises. If you see in the video also, with eyes closed and walking and moving the head sideways, that can challenge the vestibular function. In case of unilateral vestibular hypofunction, the patient will not turn the head towards the affected side usually. So when you incorporate these kind of activities, that will be helpful. And one more exercise like ankle sways, circling in ankle sways, that also will be helpful. And then one more exercise like standing and turning towards the side backward and to reach for an object. that can be used for train the vestibular unilateral vestibular hyperfunction conditions.
Thank you, sir. That was the end of our question and answer session. Heartfelt thanks to Mr. Vinod Narayan Swami for giving his time, precious time, and sharing his knowledge in the physiotherapy perspective of falls and elderly. Once again, thanks a lot, sir.
Thank you. Thank you. Thanks a lot.
We're in the end of the session. I thank our eminent speakers today, Dr. Anoop Amarnath and Mr. Vinod Narayan Swami, for making it possible and sharing their expertise in the clinical and physiotherapy perspective of the most important topic, geriatric topic in the geriatric population. My heartfelt thanks to the guests, Dr. Shitija, for coming over and then giving us a constant support and appreciating us. My cordial thanks and hearty thanks to the entire Manipal team, which includes Dr. Dhanlakshmi, Manager for Physiotherapist, Manipal Hospital, Dr. Dheeraj Adigas, HOD of PMR Manipal Hospital, Dr. Manish Roy, Director, Manipal Hospital, and the entire state IAP team, and special thanks to Dr. Iftikhar and Shuhaib, and also the major pillar, the IAP Women's Cell Karnataka team, Dr. Sumita, Dr. Shanti, Dr. Ruchi, and Dr. Ramya. I'm sorry if I missed anyone's name. The entire team who was imperative in planning and executing, and was a very meticulously planned the webinar and made it possible. I heartfully thank the entire team for giving us such a wonderful session. Thank you all the participants for having a hope on us that it will be a very good session and having logged in. It was an overwhelming response from all the participants. Thanks you once again. See you all in tomorrow's session. The tomorrow's session is on role of physiotherapy in COVID-19 hospital to community rehabilitation. It will be taken by Mr. Balachandran, Principal Physiotherapist, Woodland Health Campus from Singapore. The timing is between 5 to 6 p.m. Request all the participants to log in and make use of it. Thank you all once again. Hope you all had a very interactive session. Thank you.
Yes, such an amazing presentation. Convey our regards to him. You know, from me to physio. உங்களுக்கு ஒரு நல்ல